Thanks everyone for joining us today. My name is Kurt Burla. I use he, him, his pronouns, and I am the Senior Regional Manager for the Community-Based Research Center in Atlantic Canada. If you don't know us, CBRC is a national queer organization that promotes the health of people of diverse sexualities and genders through research and intervention health. You can find out more about us at our website, cbrc.net. I speak to you today from Chibuktuk, colonially known as Halifax, in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. At CBRC, we acknowledge that as a national organization, our work spans across the unceded, ancestral, and traditional territories of Indigenous peoples on land that is currently occupied and known as Canada. This includes the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nation, commonly known as Vancouver, which is where our head office is located. We recognize and are grateful for living and working on all these lands that have been cared for by Indigenous peoples since time immemorial. In 2016, CBRC endorsed the Truth and Reconciliation Commission of Canada Calls to Actions and the United Nations Declaration on the Rights of Indigenous Peoples. As an organization dedicated to the health and wellness of our communities, we recognize that true reconciliation requires more than an endorsement and have made a series of commitments in our work, including the full integration of Two-Spirit and Indigenous staff into the culture of our organization and delivery of our programs. We also have created and centered an intentional space at our annual summit for Two-Spirit and Indigenous, queer, and trans people. As we continue on our path of truth and reconciliation, CBRC continues to learn from our Indigenous staff and partners, reflecting on the ways our actions and social policies impact the lives of Indigenous peoples and actively participate in colonization. As you may have noticed, we do have American Sign Language interpreters available. Closed captioning is also available if you wish to use that. It should be somewhere around here on your screen, and you turn that on yourself. I am so pleased to see that there are so many people who are interested in joining our session on the past, present, and future of HIV testing in Canada. We do hope this is going to be an education and fun event. We know we can't possibly cover everything there is to talk about, but we hope this will be a lively discussion. The session is scheduled for approximately 9 minutes. If we end early, you've got some free time to reflect, but we also will hopefully address any questions that come up through the chat at the end. My amazing associate Spencer is going to collect those questions and maybe add some context. For example, if you ask a question 15 minutes into our presentation, someone's not going to remember what you were talking about an hour from now. I would be remiss if I didn't mention that there will be an evaluation shared at the end of this webinar and emailed to all of you. For those of you watching on YouTube, you don't have to worry about that. So I started with thanks to you for attending. And I want to end with thanks as well. Thanks to our amazing group of presenters today. We are lucky to have people from all across so-called Canada with a range of experiences. Our facilitator today is going to be Chris Weiss, who uses he, him pronouns. Chris is the manager of national programs at the Canadian AIDS Society. He has years of experience working on dozens of health, social justice, and environmental projects across Canada. He's worked with CBRC on a public health research pilot in HIV self-testing. He provides ongoing consulting and grant writing support to several organizations across the nonprofit sector. He grew up on a bison ranch of all places before attending the University of Saskatchewan. He then took working positions at community-based organizations in Burkina Faso, Australia, and Eswatini before settling permanently in Edmonton. He recently married his partner of many years in 2022, and they can often be found hiking or skiing in their Rockies, on seat sails to Toronto, or gardening in front of their home. Over to you, Chris. Thank you for your time.
Well, thank you so much for that lovely introduction. It's a pleasure to be a part of this event. And I would like to also introduce our panelists who were kind enough to join us today. So first, I would like to start with Darren Ho. If you're brave enough to turn on your camera at this moment, I would encourage you to do so. Darren Ho is the Director of Health Services at Health Initiative for Men and also my friend. Darren resides in Vancouver on the unceded territories of the Musqueam, Tsleil-Waututh, and Squamish Nations. As Director of Health Services, Darren oversees the ways that Health Initiative for Men's clinical services, such as testing, treatment, and vaccination, are delivered across the province. He also leads a team that develops health promotion and customized resources for gay, bi, and queer men and gender diverse people. I would also like to introduce Patrick O'Byrne, also if you were brave enough to turn on your camera for your introduction. Patrick uses he, him pronouns. As well, Dr. Patrick O'Byrne is a full-time professor of nursing at the University of Ottawa and a nurse practitioner at Ottawa Public Health. Dr. O'Byrne's research and clinical work focuses on the prevention, diagnosis, and management of sexually transmitted infections, including HIV. Dr. O'Byrne also established Get a Kit, which partners with CBRC to be one of the largest distributors of HIV self-tests in Canada. Thank you. Next up, we have Abby Ferguson, she, her pronouns. Abby is a Mount St. Vincent University Women's Studies Honors alum. She wrote her thesis on the historical applications of the theory of erotic capital. She's also the executive director of the Halifax Sexual Health Center and has been involved with the organization since 2016. She's also a certified abortion doula and a board member of Hepatitis Nova Scotia. Free time, she plays competitive roller derby at the international level. And when teaching sex ed to youth, her favorite question to answer is how to feel the cervix. Thank you, Abby. Next up, we have Mark Randall. Mark uses he, him, and they, them pronouns. Mark Randall is a long-term PHA of 36 years, advocating for access to HIV testing, treatment, diagnosis, and informed consent for research and clinical trials. Randall has been passionate about the inclusion of lived experience and knowledge to better inform and build capacity related to current science, testing, prevention, and treatment. Randall continues to support HIV self-testing and clinical testing through Reach Nexus's I'm Ready and I Am projects, and a partnership testing clinic with SafeWorks Harm Reduction in local bathhouses. For his role as Community Outreach Coordinator, Mark supports GBS MSM access to testing, treatment, and prevention resources with SafeLink Alberta. Thank you, Mark. So to move on with our panel, we're going to be diving into where we've been, where we are, and where we're going in the world of HIV testing. And where we'd like to start with is where we've been. And for this section of questions, I would like to focus our attention to Mark and Abby. And my first questions are for you, Mark. We're here today as I said, we're here today to talk about past, present, and the future of HIV testing. But of course, there was a time before testing was really available, and I know that you can really speak to that. Can you tell us what testing was? Can you tell us what things were like before testing was even an option?
That was a really big historical question that I had to go back on because I had to think back 36 years as to what 1985 looked like, which is hard for an old guy. But honestly, I was diagnosed the 1 year that HIV testing became available. So I was one of the very first folks to be able to access actual HIV testing. Knowing that before that, all we had to go by to know something was really not right in our community was young gay men were being diagnosed and dying of really odd, strange, very rare diseases. We were seeing a really bad response from community leaders around this at the time. There seemed to be very little interest in determining what was causing this. Again, is that a homophobic thing? It was only those folks. we don't have to worry about this. So there was this big anxiety of what is this? Why is it happening to queer men? Why? Lots of questions, no answers. So I think there was a lot of anxiety in community. There was a lot of fear in community. And of course, we know that fear and anxiety just breeds negative outcomes for everyone involved, especially when there's a lack of leadership. So really, that's the best description I can give for what it was like then, because I, as I said, benefited from being one of the very first folks who was able to access HIV testing.
Sure. Thank you for your insights. To add to that, we know that there was a gap between when tests were created and when they became readily available in the community. Are you able to comment on what it was like during those early days of testing?
For me, my testing result, I went in for my test and we were told, I'm going to say we, because I will assume everyone was getting the same information going to the same clinic, is that we were told your test results will be back in 2 to 3 weeks, which is lovely. But when your test results don't come back in 4 weeks, 5 weeks, 6 weeks, you start to worry. And I think in the early years, there was a lot of anxiety around false positives, people being given results over the phone, and seeing the negative outcomes of someone being given a false positive result over the phone, resulting in possible suicide and self-harms. So we knew that that was going on in community as well at the time. For me, having that additional 3-week wait for a test result was really distressing, very anxiety driving, and further made me feel like my test result was going to be positive before I even got my test result back. For me, as someone new in the field of queer, in the field of HIV, and getting a test done, my doctor was kind enough to say, your test result has come back positive, to which I went, great. Not realizing that a positive test result was not the result I wanted to hear. So that was my first real lesson in testing, medical language, HIV, what that meant, and what my responsibilities were as a result of being told you're HIV positive now. So there was definitely a lot of anxiety. There was a lot of homophobia, an immediate self-guilt and self-shaming that came with that, because the first thing that went through my head was, great, I'm another gay who just proved that this disease is about us and not about anybody. And am I now carrying that burden? Which I kind of did for a while until somebody slapped me upside the head and woke me up. And not physically, but figuratively. So there was a lot of anxiety around that. There was a lot of shame and guilt that came with that. And personally, on a personal level, I felt like I just reconfirmed the myth that was being expressed in media, through government, and through communities, that it's only about gay folks, so it's not about us.
You can read my mind. You gave me the best segue possible. I wanted to follow up on that and ask you how 2S LGBTQIA plus community members champion for better access to the HIV testing that we see today.
In typical fashion, if you want anything done in the queer community needs to do it. And that's what happened. Queer folks, no matter how you identify, 2S LGBTQ plus, wherever they were, they stood up, they got angry, they got mad, they challenged, they questioned. What we saw was community gather, particularly in the United States. I'll be honest, the big lead came out of the US without any question whatsoever. We were hearing things like, this is God's curse on gays. Like, this was the message that was coming through from folks and stuff like that. But really, the community really started to do the key things that we needed to do. We talked about what was happening. We talked about who it was happening to. We talked about the barriers that were existing to addressing the issue at hand. And we started to create. We started to meet. We started to talk, and we started to challenge. This came through things like some of the first movies of Longtime Companion and the band Played On. So we started to see the immediate media messaging coming from community to contrast to that which was being expressed in media that it's gays, Haitians, and drug users that are getting this disease. We also saw the loss of Rock Hudson and other celebrities in community that started to make people think outside that community until, of course, they discovered that Rock Hudson was indeed gay. And then we saw the creation of the Safer Sex Guide that came out of San Francisco. So we saw incredible community response. We also watched the lesbian community radically move to support queer men as they were dying of this disease when nobody else was stepping up. So without them, I don't think we would have seen much of the compassion, empathy, and medical supports that existed for us in those early days, without question. And then watching the arts community create messaging and images and stories of what was really happening to community really did help modify some of that movement. And then ACT emerged out of all of that activity and really started to move things forward.
Thank you so much, Mark. Abby, my next question is for you. As a community-based clinic, the Halifax Sexual Health Center often finds itself wedged between the provincial healthcare system and a community in need of testing. Are you able to tell us more about how Halifax Sexual Health has navigated that in the past and how that continues now?
Yeah, absolutely. I'm sorry, I can't start my video because apparently you folks have, the host has me stopped.
Oh.
Yeah, but one of my favorite parts about working at Halifax Sexual Health Center is that we are an independent, like charitable nonprofit clinic. So that does mean that we're able to work within the provincial system while also advocating to better care from the outside on behalf of our patients. And I love, Mark, that you mentioned the like really key role that the lesbian community has played in doing HIV work. And while I don't have a great understanding of our organizational history in that regard, specifically for HIV testing, we have like an archive that has yet to be filtered through. We just like surpassed our 50-year anniversary and there's a lot that hasn't been looked at in a while. We've had queer and lesbian physicians on board for a very long time. So in specifically to HIV, it was the Nova Scotia Health Authority and the Department of Health and Wellness, or whatever name it would have had at that time, that funds our anonymous and non-nominal STBBI and HIV blood draw program, which is totally nurse-led, where a nurse draws your blood right on site. And that is fully designed and implemented by the Halifax Sexual Health Center. And my understanding is that we have been doing HIV testing since as long as HIV testing has been available in Nova Scotia. So that would have been 1994, 95. Though those funds have not changed in a like comically long time, probably since the early 2000s. This is the last time we saw an increase in those funds, even though we're running the exact same program. Nor would I say that it's adequate to grow a robust program that fully addresses community need and desire for testing. But that relationship is not always so adversarial. We also have lots of opportunities to work with the provincial system to do some good because we do get to like anchor ourselves in a little bit more of a political realm. So a recent example of that would be our partnership with delivering Mpox immunizations, where we were able to partner with the Nova Scotia Health Authority, with the Public Health Department, the Department of Health and Wellness, and we provided clinics and like stood up clinics within our center using provincial funds in a really rapid amount of time, especially in the Nova Scotia context. I know in like larger cities like Toronto and Vancouver, something like the Mpox immunizations was something that was thrown up really quickly. And there's a lot of money to move around in that way, but Halifax very rarely actually operates in that way. So I do think it was a really cool example of Atlantic queer organization and leadership coming together and telling the province that this is what we need, we have the resources to do it, and we're just going to go ahead and do that.
Wonderful, thank you. I'm going to be asking you and Mark the same question as a follow-up, but I'd like to start with Mark. There's often a gap in understanding among community members and service providers between the current landscape for HIV testing and how governments and health authorities essentially abandoned community members impacted by HIV and AIDS in the 1980s. What do you think is important for people today to know about what has come before them in regard to testing for HIV?
Okay, so I took my 100-page list and significantly reduced it to as a simple thing as I could possibly come up with for you. Um, I think if there's one thing that I really want folks to know is that we would not have and be where we are today without the incredible efforts of a lot of other people before us. Everything that exists today has been built upon great loss of human lives and leaders. And today, we continue to see that same loss without seeing a resurgence of new leaders and new voices coming forward. So I think there is a great opportunity for today's folks to do better at sharing knowledge that is scientifically based and not theoretically based, to better impact the lives and outcomes and reduce the transmission of HIV among all populations.
And Abby, to ask the same question, what do you think is important for today to know about what has come before them?
Yeah, I think what is most relevant is that that context is still at play, right? So the stigma that new patients who are looking to come in for testing come in with is rooted in the exact same stigma that was created in the past, or like in a more modern, like newcomer context, rooted in stigma that continues to be perpetuated in other nations. Not that Canada is perfect. I don't want to try to suggest that at all, but it certainly has done some work in comparison to some of the like misinformation or thoughts around HIV that other folks are coming into Canada with. So I would primarily work in a clinical setting, which is interesting. So when I'm talking to like consultants, there's been some talk in Nova Scotia this year about a review of specifically the privacy laws regarding HIV testing and whether that should be folded into a traditional like the legislation that supports the rest of it or policy that supports the rest of disclosable diseases and infections. And they were kind of shocked to hear that, like, no, people still use the anonymous program for like very real reasons. The like large quantity of Nova Scotians actually live rurally and therefore are not getting the same type of like sort of big city urban messaging regarding HIV, nor would they have in the past. So those are still at play. When you're talking about getting your blood drawn, you are going to a blood lab where your aunt and your cousin are your phlebotomist, and the person who's working the lab in the small local hospital that staffs very few people is someone that you know. And there are rural folks driving many, many hours into Halifax to access one of the only anonymous sites, which is us. And then there's one up in Sydney and Cape Breton. So those stigmas are still at play. We try to think that we're past that, and policy leaders tend to think that they're past that because they're not on the ground talking to patients that are still coming in with that same exact stigma that mirrors what we would expect to have heard or have heard in the past, like coming out of the 80s, 90s, 2000s.
So I'd like to dive more into that stigma piece, and I'm going to try the same sort of format where I start with Mark, and then I'll throw it back to you, Abby. Mark, so touching more about stigma, how have historical perceptions of stigma surrounding HIV created ongoing barriers for access to testing?
The HIV stigma is rooted and grounded and firmly planted. No matter all the work that we've done over the years, many, 40 now, that is the one piece that's still in play and is left unchanged. We have folks who still think that being HIV positive is a death sentence. I still have this conversation with people. We still have people who have zero knowledge or understanding of what U equals U means, and undetectable equals untransmittable for anyone else who may not be aware of that, who may be on this call or presentation. This is like the holy grail of treatment. This is the closest we can get to stopping HIV as we've ever been. And we have government, we have frontline organizations that are not promoting this information to the people who need to hear it the most. So that's a really big one for me right now. We still have all of the phobias: transphobia, homophobia, biphobia, all the isms are at play. all of the social determinants of health that are critical in impacting people's lives, and willingness and ability to access testing in an appropriate way are all still in play. As I said, it appears that all of the real main root causes of HIV stigma have not been addressed, have not been removed. If anything, they've been amplified, pied into little groups of they, them, they, them, they, them, and has really done little to move us forward. If anything, it has forced us to work in silo and at times and in conflict. So I think there is a lot of opportunity for change.
Thank you very much, Mark. And to reflect that back to Abby, how have you seen this pervasive stigma that we're talking about in the work that you've done? I'm guessing that you've had to educate a lot of people about the changing nature of testing and treatment in your work.
Yeah, absolutely. I always feel like patients come in with like opposite ends of the 0 to 10 scale of stigma or thoughts around HIV. So either folks are insistent, like they had this like one tiny encounter that we would consider like a 0.00001% theoretical risk and no real risk. And those folks are terrified that they have contracted HIV in some capacity and they need testing now and they need it anonymously, et cetera, et cetera. Or on the other hand, folks who have never even thought about being tested for HIV because it feels irrelevant or like totally non-existent to them within their dating pools or within the education that they've received. And I feel like we see very little in the middle. It seems to come on these like two opposite ends of a binary scale. From an education perspective, I think sex education has gotten better in that they are doing way less, including myself, like way less like risk-focused sexual education. It's meant to be more comprehensive. We talk about how STIs and STBBIs are like treatable, manageable, or curable, depending on the situation. We try not to do that thing where we show the like big ugly pictures of genitals that are basically falling off. However, that does mean that I think that things like STBBIs are just being like skipped over or seen as irrelevant for youth to know, something that they'll figure out as they go along their journey, especially because like HIV rates in the like Nova Scotian context is not really hitting like a youth demographic. It's mostly older adults that we're seeing at this time. And our like most recent bump in positive cases in Nova Scotia was like a group of older adult men. So it's just not a messaging that's being pushed at all. And I agree with Mark. It's certainly not the public health department that's promoting You Equals You. It's our local AIDS coalition. It's us. It's our pamphlets that we hand out, and that is not coming in any way, shape, or form from the provincial health system at large.
Well, so Abby, I'm going to keep my focus on you, and we're going to transition a bit into where are we now in the world of HIV testing. So I'll be fielding questions to you, Abby, first, and then to Darren next. So you've touched on this somewhat, but I would like to ask you what HIV testing looks like nowadays in Nova Scotia. I'm particularly interested in this, joining you from Alberta, where so much of the population is highly urbanized. You had touched on how Nova Scotia is a little bit different and has quite a few more folks living rural. So what does it look like? What testing options are out there? What sort of challenges exist? What is the demand like?
Yeah. So the sort of setup for getting HIV tested in Nova Scotia has stayed the same for a very long time. So there hasn't been a lot of innovation or movement in this way, other than the like new innovation of HIV self-test kits. So how the vast majority of folks are getting tested is through their traditional like family doctors or nurse practitioners or through a walk-in clinic. So just like access to primary care. As most of Canada is, but Nova Scotia especially is in a primary care crisis at this time. The vast majority of the population, I can't remember the percentage at this time, but it's comically large. Like over 10% of the population does not have access to a family provider. Nova Scotia does have a new addition of a virtual care option where folks without a family provider can then like go online and get connected with a doctor where they can write you a rec and fax it over to the blood lab collection. So like all that sort of like traditional blood work access in the same way that you would get tested for your sugars or for your vitamin levels. There are only 2 anonymous HIV testing sites in Nova Scotia, and that has not changed in a very, very long time. So that is us at Halifax Sexual Health. We've been doing it since the mid-90s, and the Ally Center of Cape Breton, who I think also have had that standing clinic available for a very long time. And there's been no discussion or movement to get any other anonymous sites or any sort of expansion on that program. Specifically in Nova Scotia, what's different that compares to other provinces is that our province doesn't run their own sort of like sexual health centers or clinics. There is one STI clinic that runs out of the Victoria General Hospital here in the city twice a week, just in the evening. They do same-day appointments, but there are no other like public health department like funded or created sexual health or STI testing, which I know is really different in other provinces where almost all their sexual health centers are somehow more connected to a provincial system. And then as far as self-tests, those are pretty much only being accessed via project grants and nonprofit offices. Public health is not taking on that role at all. So yeah, it's not so great. It's pretty bleak looking out here, and it's pretty traditional, pretty rooted in the past.
I'm sorry to hear that. At your clinic, who are you actively seeing get tested?
Yeah, it's a big mix. So we are we don't have a specific demographic that we restrict our primary care services to. So we do see everybody, though we are, of course, very specifically queer and trans community focused. Specifically taking advantage of our anonymous and non-nominal STBBI program is a lot of newcomers, a lot of international students, and then folks usually older, but not always, coming in from rural communities. So there's definitely a real sort of like specific demographic of folks who are choosing to access that program. Though, of course, we're tossing on HIV test to anybody who is coming in here for a traditional STI test, or at least bringing it up and mentioning it as an option. But for the folks who are specifically going for that program, they're meeting those demographics.
Thank you so much, Abby. I'm gonna shift my attention over to Darren on the opposite coast, over on the Pacific in Coast Salish territory. Darren, what is testing like at Health Initiative for Men in Vancouver?
Yeah, thanks for that. Well, first, thanks, Mark and Abby, for really like grounding us with the historical context and the ongoing landscape of HIV stigma. Presently at HIM, we have health centers across BC. 2 of them are in Vancouver, and we also have one that's just started up again in the Fraser region in Surrey. As well, we have some pop-up clinics called Plus in the interior region. So at our health centers, for HIV, we do like standard 4th generation blood test, and we can also do point of care testing if that's necessary. We do PrEP assessments in our Vancouver locations as well. And then we also distribute HIV self-testing kits. And all of our nurses are STI certified in sexual health. Specifically for folks in the interior region of BC, we also run a program called Plus, like I mentioned, which is a private and confidential on-the-spot STI testing center or testing event for gay, bi, trans men, two-spirit folks, and queer people. Because like Abby said, anonymous testing is still very important to a lot of people for, like Abby said, very real reasons. So at these Plus clinics, interior health nurse is able to provide tests for chlamydia, gonorrhea, hepatitis, HIV, and syphilis. And then nurses also provide education, like referrals and resources for other health concerns, vaccinations, for example, PrEP, and mental health. For all of our clients in any of our health centers, we do offer the option of anonymous testing, like I said, via using either pseudonyms or fake initials. And then just to give you more of an idea of like what the testing landscape is like for us currently, our clinics are always full. Like bookings are always full, like 10 minutes after we open the appointment slot online. And that's because I guess folks are really wanting to get tested. And I guess in many ways, we've done a really good job in educating our community around the importance of getting tested. But then the part about how we're always full also is a capacity issue as well, in that, if there were more testing options available for folks who want to get like anonymous testing and peer competent testing, then we wouldn't have to turn away people every day because of just how full our bookings are. But currently, we're getting the feedback that a lot of folks are finding like HIV testing appointments hard to make, or just like hard to get to, just due to like the limited hours and whatnot.
And I'm really happy that I get to ask you this question because Darren, you and I used to collaborate on self-testing. And one of the important pieces in self-testing is how pre and post-test counseling looks compared to point of care testing.
Yeah.
So I'd like to ask you how pre and post-test counseling is handled at Health Initiative for Men.
Yeah, that's a great question. So our nurses have all been trained and are experienced in providing pre and post counseling. We actually consistently hear back from our clients about like how gentle and informative and how safe the nurses are when giving a positive results. Our nurses also like provide like resources, including like accessing specific counseling if that's what's needed. And then sometimes as part of the post-test counseling process, folks would get referred to HIMSS own like mental health counseling services, which we also provide. For point of care tests, that's done on site with a nurse, like with the same protocol. Like the same protocol is followed with the exception that they also do like a standard blood test just for confirmation for positive results. And then yeah, just thinking back to the HIV self-test option, because those are done off-site, like if they're done through the I'm Ready study, the study itself has folks who are available online and by over the phone to like help and to help with the test and then also speak with the like post-testing, the post-counseling process. Yeah, and then for other self-testing kits that we distribute, we also make a point to attach a list of resources that folks can access.
And you had mentioned that there's clearly quite the demand for any time slots that you have. What populations do you see coming in for testing?
Yeah, so at Health Initiative for Men, we primarily serve gay, bisexual, queer men, as well as gender diverse folks, which includes two-spirit people and trans people. And currently we are seeing like primarily folks who are gay, bi, and queer men, and some folks who identify as gender diverse. And then within those groups, we see a diverse array of folks from different intersections. So at our Vancouver clinics, we see people of color from various communities and various language backgrounds, particularly Spanish-speaking Latino community members currently, also like students who have traveled abroad, and also folks from outside Vancouver who kind of make the way to Vancouver to get tested from the suburbs. So that's like the primarily the populations that we see, and we tend not to turn anyone away, even if they don't identify within our target populations that we serve. But we also do our best to let folks know about other testing centers, if they are someone who can get competent testing services elsewhere. Like, for example, if they're a straight cis woman, for example, just because, like I've mentioned, we do have limited slots for testing, and we unfortunately do have to turn away folks just due to capacity. But we try our best to accommodate everyone who needs our services. And then beyond that, very quickly, I just want to say that this is kind of, I think Abby mentioned this as well about seeing like the 0 to 10 around like the folks who come in around their like knowledge around HIV. We see a lot of first time testers, and these are folks who we hear like really appreciate our nurses spending a bit of extra time explaining like the process of testing and things like window periods and how everything works. And then we also get a lot of routine testers who are like already very familiar with the testing process. And for these folks, because they are so used to the process as already, we give them the option to do express testing where they don't need to see a nurse. They're just here to get their blood drawn with a phlebotomist because they're already very comfortable with the process. That's quick and it's easy.
Thank you so much, Darren. My next question is going to be for you, just so I don't catch you off guard, but I'm just getting a note here. I wanted to point out that our next panelist was to be Mario Johnson, a community health outreach worker supporting the Black Coalition for AIDS Prevention and its communities all over the Greater Toronto area. Unfortunately, Mario could not join us today, but we just thought it was important to note that Mario is a full-time worker at Black Cap. He focuses on outreach to shelters, conferences, universities, bathhouses, and anywhere in the community that there is a need for testing. And part of that work is doing education with community members and collaborating with harm reduction projects. And so Darren, you're going to be taking over my next question that I had for Mario from a Toronto perspective, but because Vancouver is also just such an urban environment, I want to ask you if there's any new approaches to testing that you're excited about, and how you hope that might address any gaps in testing that you see.
Yeah, so what comes to mind are like new approaches, but if you are like really thinking about like the stuff I'm going to mention, they're not that new. But I mean, okay, so that will make sense as I explain. So last year we learned from our partners at Réseau in Montreal about an initiative called La Zone Rose, where they test folks out of a pink shipping container out of Montreal's gay village. You know, it's like very vibrant, very eye-catching, and it was just like a very seemingly new approach of having like another accessible testing option for community members. So that was really cool. But then, you know, when you think about it, like those kinds of testing sites is not new because, you know, folks have done testing out of like different, like unique areas, meeting community where they're at since a long time, as I'm sure folks like Mark can attest to. And then so like similarly, you know, we at him, we want to have like more testing options available for more folks. So we are looking into having testing options like a mobile testing van, you know, which is something that we've done in Vancouver in the past before. We've done this with in partnership with an organization called YouthCo, and it was a project called Know on the Go, as in like know your status on the go. So again, this is not a new approach at all, but we're like I'm excited to in some way bring back some of this like mobile fun testing options in some capacity. And then just in general, I think like outside of the clinic spaces, just being more present where community members are at, I think is very important. Um, for example, like testing options at our nude beach, like Wreck Beach in Vancouver, or bathhouses. You know, this is where gay men meet. This is where our community is at. And I think it would do a lot to meet our community members there and offer testing at those locations. Um, but again, like, you know, your questions like new and exciting approaches. And this is very exciting for me, but I know that this is stuff that we've done before. And, you know, we're just excited to put more effort into making those options more available and more accessible.
Great. Thank you so much, Darren. I think those are great ideas. I'm going to ask a similar question to Abby. Is there anything new and exciting about testing in Halifax that you want to note?
Well, self-testing was like revolutionary for us, which is very cool. So as I mentioned, like with there being so few clinics and so much access to HIV testing through traditional means that folks may not want to engage with based on stigma or whatever other concern. Self-tests were very cool. So for the other sexual health centers in the province, which we do have a network of them, I'll run through Sexual Health Nova Scotia, they are all resource and education based. They are not clinics. We are the only like independent one in that regard, or like independent clinic in that regard. So to be able to give some sort of like clinical initiative out into the world, into the rural sphere where folks can get tested, at home with a support person at the sexual health center with their partners or with whatever community they have in their own region was very powerful. Now I know there's been like that decrease in funding when it comes to self-tests, so we'll see where that goes. Though I would be interested to see what some pressure on our public health department would sort of speak to, because we definitely know that our public health and our 811 like registered nursing line has been sending folks to nonprofits specifically to get access to these tests. So clearly that is indicating that they understand that they're important. We did have them also admit sometime last summer when we had a small bump up in positive HIV cases that self-test played a role in like discovering this like network of folks who had all tested positive. So, you know, I don't know how that's going to play out, but I'm definitely interested to see what it looks like. And then I think we're also getting more used to like a low or no touch sort of sphere of medicine when it comes to accessing primary care. So something like using virtual care where you don't actually meet someone in person to get your requisition. That's great for those repeat testers, like you were mentioning, Darren, that are like, I'm over it. I've been doing this forever. Just give me my rec and let me move on with my day. That's really fabulous. Of course, it doesn't meet the needs of every patient, but can be quite effective. And the STI clinic out of the Victoria General Hospital is also starting to apply for some funds for things like Get a Kit, where folks can take their testing needs back home for not just things like SVBIs, but also swabs and urine for chlamydia and gonorrhea. So I'm interested to see where they go. I feel like they're all shifting landscapes, but we don't have anything like big and promising looming on the horizon for us, unfortunately.
That's okay. Fair enough. I really appreciate that insight, Abby. But to move into, you gave me another brilliant segue because I'd like to talk about where we're going. And with that piece, I'll be directing my questions to Patrick. Patrick, I'm wondering if you're able to provide any insight on new testing technologies that are being developed and how those might provide additional options for community members.
Thanks, Chris. Yeah, it's super interesting. When we go back to 1985 with antibody identification, right, and really the first tests that were mentioned earlier on. But it's interesting to see how we're developing. And we've moved forward from just these first to second to third, and then to what we call now the fourth generation blood tests, right, where you actually do it and it detects not just the antibodies, so not just what your body uses or develops in reaction to HIV, but also to be able to test for, it's a protein, it's a little piece that's actually on HIV called P24 that probably a lot of people have heard of. So like this was a pretty revolutionary thing for the testing technology, reducing window periods to 6 weeks. We're able to detect new infections after probably around 17 days, pretty accurately at 3 weeks, in fact. So this was great, right? This is kind of bringing us up to where we are. Then the self-test came out and the point of care tests, and this took us back a little bit to the third generation tests. These are antibody only tests, so they still have the 3-month window period. They're not as accurate as the blood test and the serology when we do the draw, but they give us a new access point. And so I think when we're looking at what is the future look like for HIV testing, there's 2 veins to it. The first is the actual technology, like what is the test itself? We're moving forward now into point of cares and self-tests that are not just blood-based, because lots of people got super excited over the self-test, rightfully so, but there's still a bunch of people who really don't want to poke their finger, right? It's still a blood-based test, and people with phobias issues in that regard, this is still a barrier to them. So moving into validation of saliva and cheek swab-based tests, right? This is important to say, right? There's different options for different people. Still massively missing from this realm, though, is, and I don't hear this talked about enough in relation to self-test, is if you have a physical disability, right? If you don't have use of one of your arms, you don't have a second hand, or you're visually impaired, these devices are actually useless for you, right? So we are getting super excited about, right, what we have, but at the same time, our excitement and all of this energy we're building is further marginalizing certain groups, right? So it's not just the device itself. As I said, it's also the access. And in that second realm, this is where people are going forward and saying, how do we do novel forms of outreach? Vancouver, British Columbia has had Get Checked Online for a long time. which is a good platform. And then over in the East, so Ontario, we now have Get a Kit. And Abby, I think you were mentioning that, yes, we are working with Nova Scotia Health to figure out how to actually launch this for Halifax, to say how can people get access to testing in totally different and new ways. How can we do outreach into bathhouses, into the pink shipping container that they have in Montreal? So it's moving in those two realms to say we need new devices, we need better devices, we need viral load testing that can be done, but we also need to not just get excited about a device and say, we can diagnose, but the issue is how do we reach populations and groups and individuals who are apprehensive about seeking, right, us, about people who don't know, about people who are, right, uninsured. How do we actually create that? So I think there's a lot going on in both the development of the new technologies, plus this newfound interest in actually going out and inverting that language of hard to reach groups. It's not the case, it's hard to reach services, right? So how do we actually get rid of that hard to reach on the service side and get back out into communities and, right, help people with the services?
Thank you, Patrick. You have a knack for explaining complex topics in a way that I and I think the other people who are participating can understand. I wanted to ask you a similar question, staying on that topic of emerging technology, but more into the prevention side of things. So what is coming in the pipeline that offers additional options for HIV prevention?
Again, I'm going to move, I think, through a historical thing here where we went from use condoms, don't have sex, abstain, zero sort, strategic positioning, and then the world was blown apart with HIV PrEP, right? And we came with the single drug Truvada, M-tricytamines and alphavir DF came out. But then not everybody could handle it, some side effects, kidney issues, and then to make it even better, we came out with a new one, right? Our Descovy, our M-tricytamines and alphavir AF. So this is good, right? We have two different options. And then to further revolutionize things, what's the next one? It's been approved in the United States and is under Health Canada review, is cabotegravir, the long-acting injectable, right? And Cabenuva, where cabotegravir is mixed rilpivirine, is actually a treatment. And some of you right here may actually be taking this injection. It's currently under review, not just for treatment, but now for actual prevention. I had hoped it was going to be a lot more than it was. I am a bit of a bearer of bad news. You do have to start with an oral regime. You have to be doing viral load testing, which is not available everywhere. And then it can actually produce drug resistance for up to 12 months after if you decide to just discontinue it, and you're supposed to go back onto oral medications. So for the individuals who can take it, excellent. It's a third option, but I don't want everyone to suddenly get super excited and say, wow, this is going to solve everything. We just inject a whole bunch of people with this and suddenly it's going to work. No, that won't be the case, but it is a new intervention. What I think is showing a bit more promise, and this is going to seem like a weird tangent, is actually DoxyPEP. And you're going to say, why am I talking about a prevention with an antibiotic for STIs when we're here talking about HIV testing? And I'm going to take a long way around to actually land this point. So DoxyPEP, what is it? Doxycycline is an antibiotic. I would say almost everyone who's on this call has taken doxycycline at some time for malaria treatment, malaria prophylaxis, for syphilis treatment, for chlamydia treatment, for acne, for ear infections, for chest infection. It's a common standard antibiotic. So PEP, what is PEP? Post-exposure prophylaxis, something you take after, right, a potential exposure. Most of us have used some sort of PEP. Your cat bit you. My cat actually bit me not that long ago, and I ended up taking doxycycline specifically for that. But you go in, your cat bites you, you go to a clinic, and they're like, there's a high risk of an infection from your cat bite, so they put you on doxycycline. That is actually a form of DoxyPEP, but for here we're using it for STIs, and it does works exceptionally well. What's the link with STIs and HIV is British Columbia, Ontario, Halifax, Quebec, Alberta, everyone in between has identified pretty consistently that people who are diagnosed with gonorrhea, chlamydia, particularly if it's in your butt, infectious syphilis, there's a high number of people who it's basically 6 to 12 months after getting a new infection of syphilis, do become HIV positive. And so DoxyPEP is, right, an intervention to, one, reduce your risk of acquisition because you don't have the inflammation of the infections, but secondly, to link people into care, right, to link people into STI testing, and in linking in for, right, this one intervention where people are like, yeah, I'm a lot more at risk for chlamydia probably than anything else. It's just by numbers, that's the case. It gives us that linkage to come in and say, well, how now do we link you back to routine HIV testing? How do we also link you into HIV PrEP? So I think it's this like bigger view that we're starting to move toward, where we've in our sector focused on HIV, right, with blinders for such a long time that we're now saying, wait, chlamydia, gonorrhea, syphilis, if we can actually start working on prevention for those, there are direct tangible benefits to HIV prevention. So I think this is where that future is going, that it's the injectable for PrEP is here, right? It's available in the US, but it is a bit complicated. It will work for some, but not others. But DoxyPEP, I think, is a great new entry point for a lot of people into that HIV prevention, diagnosis, treatment, care cascade.
So to see these advancements, we're likely going to need partnership from orders of government. And I wanted to ask you, Patrick, what future investments from federal and provincial governments do you hope to see in relation to testing for HIV?
Mm-hmm. For this, I would love to see two things. The first, actually three. I would love to see three things. First, I would love us to, as I just said, stop just focusing on HIV, right? Let's focus on sexual health. Let's focus as part of that on people who get pregnant, contraception. It's any door is the right door to bring you into HIV testing, to HIV prevention. And I would love for us to stop sort of whack-a-mole style reacting to, oh, syphilis is up. Now let's talk about syphilis. Oh, gonorrhea is now getting some resistance. Let's talk about that. Let's talk about them all continuously. So I think these investments need to say, certain populations will feel more at risk for chlamydia, for gonorrhea, for syphilis, for HIV. Whatever the actual hook is, right? Let's focus on all of these things so that each group actually does end up coming in, gets tested comprehensively, and we can give the full services. The second thing I would love is that we really go into a focus where it is not a top-down model. I think, like just in one of the ways self-testing has rolled out, it has been a rather homogenous model to say, here's how self-tests are available across the country. That's lovely, but in fact, it sort of defies a bit of the 2023, 2024 World AIDS Day, UN AIDS slogan, which is let communities lead. Like, how do we actually go to people and say, what are the ways for us to get testing into your communities, as opposed to, here's the model we're about to just dump and drop testing into you for. And then, yeah, one size does not fit all. This may be, right, in health services, in testing services. This may just be for your sexual preferences. One size doesn't fit all, right? Go and think that we need to actually tailor, tweak, and modify things for different groups. And lastly, one of the messages I would love to really drive to policymakers is self-tests bring something to the table, absolutely, but we shouldn't let the use of as I talked before, an older technology, right? It is inferior to the blood test you get in a clinic. Our ability to deliver this shouldn't make us pat ourselves on the back, because if you actually take the message that we're driving, we're saying people who are Black, people who are Indigenous, guys who have sex with guys, people who are trans, have horrific experiences accessing healthcare. This isn't, right, a secret to anybody. And then what we did is we said, instead of fixing a healthcare system that is shitty, right, a healthcare system that is homophobic, transphobic, misogynistic, we said, let's tell people, let's give them a test that they can do at home. Instead of, right, with the support, with the care, right, of sort of supportive, culturally sensitive healthcare providers. So I say, yes, we have a problem right now. Rights are ongoing. People, right, have undiagnosed HIV. Let's get them the self-test, but let's not let policymakers celebrate. Let's keep their feet to the fire and say, you've given us a subpar intervention for groups, right, that are equity deserving. It's good now. It's a Band-Aid. but let's get to the root cause of why people are bleeding in the first place. Give us better interventions. And so this is where that would be that third point of what you've given us is a start. We want to see more.
I love this panel because you folks keep giving me the exact segue for where I want to go. So you all have quite a knack for this. I wanted to open things up a little bit to all of our panelists, but I'm sorry, Patrick, because you just turned your camera off, but you're speaking so well that I'm going to go to you first. So we were just touching a little bit on gaps that we're seeing, and how gaps in the healthcare system might be contributing to rising rates of HIV. And I'm just wondering if you have any additional insights into how developing technologies or new approaches might address those gaps.
So I'll speak a little bit on this to Getikit, which is probably best known in Ontario across the country for being like a delivery system for HIV self-tests. What a lot of people don't realize is actually in most of Ontario, we deliver full STI testing, right? So people can go on, we'll mail out swabs, oral swabs, rectal swabs, requisitions for urine testing, requisitions for blood testing, Hep C, syphilis, HIV. It's around 30% of people who use this system, and we get approximately 200 to 250 people tested through the system per week. So that means it's around 12,000 people per year are going through and actually getting full STI testing. So that 25 to 30% say they've never been tested before. It's approximately 21% identifies African, Caribbean, Black, or Indigenous. And so I think in addition to outreach, like these new strategies for providing services to people is a good way to actually increase access. Again, I'm going to rely just on what I just said, though, and say that forcing people to go online where you know the computer is not going to stigmatize you isn't great, but we do need access in the meantime. So moving forward, what would I like to see? Same thing. Let's stop myopically focusing on one infection at a time. We spent 2 years focusing on COVID. A lot of STI testing centers and HIV testing services were shuttered. And then now we're sitting back after the pandemic and saying, why are infection rates up? Well, it's not that people stopped having sex. It's that we stopped being able to provide testing and then treatment to people with new diagnoses. We stopped preventing STI transmissions, which is directly linked to your risk of HIV acquisition. Right? We kind of created a situation inadvertently, I feel, that led us to this. We've also, though, spent 40 years talking about safe sex. And I mean, it was absolutely important before, but we spent 40 years talking about safe sex that exclusively applies to HIV. And look at syphilis, for example. I see patients day in and day out, and they say, but I did everything they told me to do. And I said, yeah, because the safe sex that we know for HIV says for anal sex, use condoms. For internal sex, use condoms. For vaginal sex, use condoms. I was like, you're going around giving blowjobs, right? You're going to get syphilis from that. And it's not something that we converse about, I think, enough. So it's to broaden our lens to say, there's more than just HIV. There are these other infections. They're all intrinsically linked. Let's bring new access points. But again, let's not be satisfied with where we've gotten to. We still need to do a lot better.
Thank you so much, Patrick. Darren, to throw it over to you, do you have any insight into what must be done differently in terms of approaches to HIV testing to reach populations that are disproportionately affected?
Yeah, so first thing is like 100% to everything that Patrick just mentioned. I also think that we need to be proactive in reaching communities before a rise of positive test results, you know. And I think for example, as I mentioned, you know, the Latino community in Lower Mainland is just an example of like one that's been growing quickly, and so it's an example of a community that it's worth it to invest in making, you know, our services, or at least, our print resources available in Spanish and perhaps Portuguese. And I think it's important to pay attention to the demographics and like special social issues, affecting our communities. Because this is what can give us insight into what populations are migrating or are traveling or residing in our different regions. I also think that we need to do the work of assessing how to improve our services to do better for underserved communities like Black, African, Caribbean communities and Indigenous folks. So cultural competency like encompasses everything from like how we're promoting ourselves to like every facet of the client experience, like how are questions asked on our intake forms, the posters that we have up in our spaces, are they inviting? Are they speaking to certain communities and so on? I think it's important to look at this from all angles if we're trying to reach communities that we want to prioritize and communities that we think may benefit from HIV tests, which is actually all communities. I think it's also important to take on different strategies for different communities. For example, in more rural and remote parts of BC, like interior, we have to focus on reaching populations that are not as out about their sexuality as folks in bigger cities. And we know that these are folks who may require more nuanced care when it comes to talking about the sex that they have. And one example that comes to mind is, for the process of getting PrEP is seemingly supposed to be like the same across BC. But what we're finding in the interior is that, folks get on the teleprep line and talk to a nurse practitioner about wanting PrEP. And then when they get to the part around the HIRI questions, it's the questionnaire that a nurse practitioner uses to assess whether or not you're a good candidate for PrEP. There's the questions around like, are you having insert of unprotected anal sex? And for a lot of guys, this is like hard to say over the phone, yes, I am having anal sex. And so their answer is no. And because their answer is no, they are seemingly not eligible for PrEP, And so I think it's a lot of these nuances that have to be taken into consideration around like how are we serving different clientele? How are we like improving our services for specific communities like populations who are not as out in order for folks to get the care and the tools that they need, like PrEP. And then lastly, I think like moving beyond like testing services and just around like HIV in general, I think what we need to do is keep preparing and educating our communities about long-acting HIV treatment and prevention tools like injectable ARVs that was just mentioned, or injectable HIV PrEP. And then we need to keep advocating to make sure that these options are accessible to the folks who need them.
Wonderful. And to continue with that theme, I would like to ask Abby a similar question. And I'd like to ask you about priorities that you've seen identified in the community that need to be incorporated into these emerging interventions or technologies in testing.
Yeah, so specifically in Atlantic, like systemic landscape, what's really interesting for us is that we're constantly consulted, like myself and my colleagues working in this sphere are consulted constantly, but nothing is ever really done. And like one specific situation that I like to pull through, so I thought this was such a fascinating Zoom call for me, is that last summer, as I mentioned, Nova Scotia had a small uptick in HIV infections. So when the Department of Public Health and the medical officer of health like had the Zoom meeting to let all of us who work in the sphere know, so myself, AIDS Coalition, et cetera, all they wanted to do with that information was promote our testing out into the world. They're like, oh, okay, we'll just make sure that we like put something out on the like provincial socials to let folks know to get tested for HIV through Halifax Sexual Health. And we're like, no, like we book like 900 appointments for all types of sexual health care within 24 hours sometimes at the center. Like that is not an effective way of using your community partners for that. So their initiative was not, let's stand up some provincially funded testing clinics. Let's give you some funds so you can bring in some extra nurses to do some more blood draw clinics, like there was no communication there. They were really thinking that just promoting HSHC was going to solve their problems, which is fascinating because again, when we're constantly consulted and constantly telling them that like we cannot meet gaps left by a provincial system that is not addressing its concerns. And I love what you said, Patrick, about, you know, like we give you an HIV self-test kit as if that solves anything, as if then someone is not then stopgapped immediately as they try to access confirmatory testing that simply doesn't exist in their community, and they have to travel all the way to Halifax. So when it comes to like integrating communities, nonprofits, you got to really think about the realities of the system that you're working within. Yeah.
Thank you. I really appreciate that. And I want to toss things over to Calgary. Mark, we were talking about early HIV activism to start this panel, and I'm just wondering if you have any words on how we can reinvigorate that revolutionary spirit of activism into future testing.
When you shared that question with me, it was like a doozy, because I don't know how we reinvigorate folks into a time that is no longer here. So if we look back at the snapshot, people were dying very quickly, and a lot of us. So there was an action involved, and today there seems to be this apathy that amongst a lot of people that HIV has been cured out there. And so we have a lot of people with this information. We have a lot of folks who know nothing about U equals U, particularly queer, gay, bi men who have sex with men. We're not inviting the people who are most impacted into the conversation. We keep talking at them and not creating spaces for them in. So we're not letting them lead. What else? We're not promoting the successes that we've had around testing, around U equals U, around the outcomes. There is just this lack of knowledge of where we were compared to where we are today. And where we are today is profoundly different and better. But as Patrick mentioned, everything we've created seems to have been created for people of privilege, with ability, with access. And we're still not meeting the folks who don't have that access. So again, we need to go back to getting the folks who need to lead be part of the conversation. We need to remove the current systemic issues and barriers that continue to exist. Criminalization of non-disclosure of HIV status. Oh my God, how do we fit HIV under all STBBI strategy when HIV is still this unique thing that has never been addressed, and that's criminalization and stigma. So until we start doing those, how do we invigorate the next generation of people to come when we are still dealing with the same shit from 40 years ago? That's my little rant. But I think we have an opportunity to tap young people and the next generation. We just need to figure out how it's done. YouthCo, amazing example of how that can happen. Réseau, doing great things in Quebec with young people as well. So I know that there's programs out there that have worked, but I think we all continue to struggle with the biggest issue, and that is the capacity to provide services. We have tools, we have testing options, but they're not meeting the needs of people where they're at. So we need to do more to bring this information and resource to those folks, and they will take it and lead the next generation through.
Thank you so much, Mark. And I'm going to be asking all four of our panelists the same question. So I'm going to lead with you, Mark, and then cycle through. Do you have any just final words that you would want people to take away from their time with us today? A closing thought?
Turn my camera off instead of my mic.
That's
Sorry
okay.
about that. Closing thoughts. We have made incredible strides when it comes to STBBI testing, prevention, and education. I think we need to build upon these successes. and do a better job of promoting them. We need to engage our communities. We need to engage government. Oh my goodness, we really need to get government, public health organizations onto page with us. We need to be having the conversation. Wow, it's just so much. But I guess in the end, huge success around testing. And if people are not getting access to testing, we're not stopping the transmission forward of all STBBIs. So we're keep shooting ourselves in the foot if we don't do the steps that we need to take. That's pretty much it. Capacity, capacity, capacity.
Thank you. And to Abby, Darren, and Patrick, maybe Abby, I'll start with you. Any closing words that you would like people to take away today?
Yeah, I think I'll toss out there that if folks are feeling invigorated by this conversation, and like kind of branch off from Mark about, you want to try to get that revolutionary spirit back into the work that is happening today, which can feel like such a slog as I'm like talking to the worst bureaucrats known to man. Your local sexual health center or queer organization probably needs and wants volunteers. That's a great way to get involved and to be the type of person that now all your friends text you random questions about their risk for chlamydia based on their weird hookup that they had last night, which is, a special role in my life that I love to be, and you too can be that person. So you can start that groundwork of getting yourself educated, understanding how the systems work as you work at a clinic or, go to a social event or run a pride table. And then that spreads out more naturally throughout your friends without feeling like you have to be the one that's like standing up some like huge rally or something like that. It's a much more quieter way to be involved that I think is really rewarding and offers really practical assistance to those of us who are hustling out here.
Thank you. And Darren, how about you?
Yeah, so I have three things. The first one is, as Mark said at the very beginning, sharing information that is scientifically based is important. And so sharing infographics from orgs like CBRC or HIM on Instagram, very easy peasy thing that we can all do and should keep doing. Second thing, promoting U equals U contributes a lot to ending HIV stigma, and we should not forget that. And then lastly, combination prevention. Let's also not forget about condoms as a prevention tool. Let's keep educating folks around incorporating condoms with testing, with PrEP, with doxy, and with treatment as a whole combination sexual health strategy. That's all.
Great. Patrick, any closing thoughts?
Yes. I'm going to say, let's look at the past. And we sometimes like to criticize it, but remember that we only got here because of incredible efforts by the people who came before us. And I think in saying that, we need to look at what did people who came before us, what was it that they actually did that got us to where we are? And it was constant advocacy, constantly pushing, constantly asking for more, never being satisfied with the status quo, not accepting stigma. We do a lot and say, like, how did they do that before? Like, why did they think this was a good idea before? But we're only here because we are, like, to use the phrase, standing on the shoulders of giants. And I think we need to have some introspection and some humility to say, like, what did these giants do? They never gave up, right? They pushed forward in momentous ways, in ways that we should all be proud of, right? And really look and say, what can we do? And it's like all of the ideas that the three people have said before me, let's push for these things. Let's continue to do it. Let's act like, right, the community elders, like the peers, like everyone who came before us, and let's do the same thing. Let's do what they did.
Thank you. So that is the last of our questions. But to all of our panelists, if you have any links to your organizations that you would like anyone to have access to, I welcome all of you to drop links to your organizations in the chat. If we can bring up our closing slide. I just wanted to, first of all, thank everyone who attended today. especially our panelists for giving their very valuable time. Please remember to do our evaluation. As you all know, evaluation is critical to helping us do the best work that we can. We've dropped a link to that in the chat, but we'll also be emailing a link to that evaluation following this, if each of you can be kind enough to fill that out quickly. And I also wanted to acknowledge that the time that we've had today was only made possible through funding by the Public Health Agency of Canada. So thank you so much to our funder, and thank you so much to all of you. You take care.